You know, when you spill dark red wine on a pristine white carpet, your instinct is just immediate, right?
Right.
And it is completely uncompromising,
Oh, yeah. Panic sets in.
right? You do not look for like a gentle, nuanced fabric cleanser. You go straight to the cabinet, you bypass all the mild soaps, and you reach for the bleach.
You want the absolute strongest thing you can find.
Exactly. You want the most caustic, most overpowered chemical to just obliterate that stain. And the funny thing is, when it comes to household cleaning, that brute force approach, well, it actually works.
It does. It gets the job done.
But what's fascinating, and frankly, kind of terrifying, is how naturally we transplant that exact same mental framework into our own biology.
Oh, absolutely. We do it all the time.
Right. Like you're sitting in a clinic, you're sweating, your fever's spiking, and you look at the physician, and you, the equivalent of the bleach question, you say, what is the strongest antibiotic you have?
Yeah, it's the desire for the nuclear option. Because you're physically miserable, so you just want a pharmacological weapon that mirrors the intensity of your symptoms.
Right. But we are pulling apart a document today from the independent medical information platform, iMedix, and the title of this deep dive is Beyond the Silver Bullet, The Truth About Antibiotic Potency.
Such a great title, honestly.
It really is. And the central thesis here completely upends that intuitive brute force mindset we just talked about. Because asking for the quote-unquote strongest antibiotic isn't just a flawed question. In the realm of infectious disease, it is actively sabotaging your own treatment.
It really is.
It's this massive collision between human psychology and clinical pharmacology. And so today, we're going to connect the dots between that medical reasoning, the patient misunderstandings, and the broader safety implications for, well, for all of you listening.
And that collision is exactly why independent platforms like iMedix have become so essential right now. I mean, we're living in this bizarre information paradox.
How so? Like, what do you mean by paradox?
Well, think about it. You can pull a smartphone out of your pocket right now, and you can access the raw, highly technical pharmacological data for literally any drug on the market.
Oh, yeah. WebMD, Wikipedia, FDA databases.
Exactly. You can look up the pharmacokinetics, the half-life, the binding affinities. The data is just ubiquitous. But the iMedix framework points out that this hyper-availability actually increases public misunderstanding of medication risks.
Okay, let's unpack this. I want to challenge that slightly. Because isn't the democratization of data generally a net positive?
In theory, yes.
Right, because if I have a bacterial infection, I can look up the exact minimum inhibitory concentrations, the MICs, right, of different drugs online. Shouldn't that make me a better advocate for my own health? I mean, it seems counterintuitive that giving people more data equals less understanding.
Well, it's a net positive only if you possess the clinical matrix to actually interpret it. The data without the context is, frankly, dangerous.
Okay, give me an example.
Let's say you look up a highly potent broad-spectrum antibiotic. The clinical trial data lists a 1% incidence of severe renal toxicity and maybe a 0.5% incidence of drug-induced hepatitis.
Which sounds terrifying.
Exactly. Without clinical training, you have absolutely no framework for probability or dosage scaling or the risk-benefit ratio. You might look at those numbers and think, oh, wow, this is rat poison. I'm not taking this.
Right.
Or conversely, you look at its kill rate in a Petri dish, you ignore the toxicity data entirely, and you demand it from your doctor because it looks like the strongest option on paper.
Wow. Yeah, I see that.
This is the gap that iMedix is trying to bridge. They provide the independent translation between raw clinical trial readouts and actual patient reality.
So it's basically the difference between handing someone the raw, complex schematic for a jet engine and actually teaching them how to fly the plane.
That is a perfect analogy, yes.
And I imagine the algorithmic nature of our digital ecosystem just, pours gasoline on this whole thing.
So it amplifies it 100-fold.
Yeah, because if you search for information on a drug, the search engine doesn't reward the nuanced, center-lane reality of clinical appropriateness. It rewards extreme engagement.
Exactly. The algorithm favors the absolute.
Right. You either get a terrifying forum post about someone whose life was completely ruined by a rare side effect, or you get this glowing, miraculous review saying it cured everything overnight. The boring reality of medication safety just doesn't go viral.
It doesn't. And when you combine a digital ecosystem that deals exclusively in absolutes with a patient who feels biologically vulnerable because they're sick, you cement this deep expectation for a silver bullet. And, the history of that term is actually deeply intertwined with the history of medicine itself.
I was actually going to ask about that. Because the iMedix document explicitly uses the phrase beyond the silver bullet. Where does that expectation actually come from?
It goes back over a century, actually.
Because we treat illnesses today like we're the protagonist in an action movie, right? The bacteria is the villain, and we just need the director to call in the biggest airstrike. How did we get there?
So the term magic bullet, which eventually evolved into the silver bullet concept, it was coined in the early 1900s by Paul Ehrlich. He was a Nobel-winning scientist.
Okay. What was he looking for?
He was searching for a chemical compound that could be introduced into the body to hunt down and kill a specific invading microbe, but without causing any collateral damage to the human host.
Hence the magic bullet. It only hits the bad guy.
Precisely. And he actually found one of the first targeted treatments for syphilis, an early drug called arsphenamide. But honestly, it was the discovery and the mass production of penicillin in the 1940s that truly cemented this in the public consciousness.
Because penicillin was, for all intents and purposes, magic at the time.
It was. I mean, people who would have reliably died from minor scratches or simple infections were suddenly walking out of the hospital days later. It completely changed the paradigm.
So the medical establishment itself essentially built this mythology.
Yeah.
We handed the public a literal miracle drug 80 years ago, and now we're frustrated that the public expects every single prescription to be a miracle.
Exactly. We program the expectation, but biology isn't static. The fundamental problem with the silver bullet mentality today is that it assumes potency operates on a linear scale.
What do you mean by linear scale?
Patients think of antibiotics like a progression of explosives. You start with a firecracker, and if that doesn't work, you move up to a stick of dynamite, and if you're really sick, you demand the thermonuclear bomb.
But wait, if I'm looking at this from a purely mechanical standpoint, let's say a patient is presenting with a severe systemic infection, their blood pressure is tanking, they are in full-blown septic shock. Don't doctors actually use the thermonuclear option? Like, don't they escalate the sheer power of the drug based on the severity of the illness?
They escalate the scope, but not necessarily the power. And that is a crucial pharmacological distinction that people miss.
Okay, wait, explain the difference between scope and power.
The iMedix framework emphasizes that medical reasoning regarding antibiotics is fundamentally about matching the precise tool to the specific biological problem. It is not about brute force. To a clinical pharmacist or infectious disease specialist, the best antibiotic isn't the strongest one. It's the most appropriate one.
Okay, let me test a metaphor here, see if I'm tracking.
Go for it.
If I have a mechanical watch that has just stopped ticking, and you hand me a massive sledgehammer, which is objectively the strongest tool in my garage, hitting the watch with the sledgehammer is going to destroy the watch entirely.
Why? Total destruction.
It technically resolves the issue of the watch functioning incorrectly by annihilating the watch itself, but it's a catastrophic solution. So medical reasoning is more the process of identifying the exact microscopic screwdriver needed to turn one specific gear.
That is a highly accurate way to look at it. Yes. And to find that microscopic screwdriver, doctors don't look at a linear chart of weak to strong. The source material points out that they evaluate 4 distinct pillars of medical reasoning.
Okay, what are the 4 pillars?
They are the organism, the site of the infection, the resistance patterns, and the patient's individual factors. If we break these down, you'll see exactly why the sledgehammer approach fails at a biochemical level.
Let's absolutely pull those apart. Let's start with the first one, the organism itself.
Right.
Because I feel like the public generally views bacteria as just a monolith, just as germs, right?
Yeah.
But from what I understand, the architectural differences between bacteria are so vast that a drug designed to destroy one type will literally just bounce off another.
Oh, yeah. The differences are astronomical. The most fundamental division in microbiology is between gram-positive and gram-negative bacteria.
Gram-positive and gram-negative, I've heard those terms. What do they actually refer to?
It refers to the structural composition of their cell walls. So gram-positive bacteria, like Staphylococcus or Streptococcus, they have a very thick, porous outer wall made of a substance called peptidoglycan.
Peptidoglycan, okay.
Yeah, think of it like a really thick sponge. Many of our older antibiotics, like the original penicillins, they work by binding to the enzymes that build this sponge. And when they do that, it causes the bacteria to essentially rupture under its own internal pressure.
Okay, so the drug basically sabotages the construction of the wall and the bacteria pops.
Exactly.
What about gram-negative then?
Gram-negative bacteria, things like E. coli or Pseudomonas, they are entirely different beasts. They have a much thinner layer of that peptidoglycan, but, and this is the key, They possess a highly sophisticated, impermeable outer lipid membrane.
Like an armored shell?
Exactly like an armored shell. And embedded in this armor are these tiny channels called porins. If an antibiotic molecule is too large or if it has the wrong electrical charge, it cannot physically pass through the porin channels. It will just bounce off the armor.
Wow, so if I have a severe gram-negative infection and I go to the doctor demanding a massive, super strong dose of a drug that was designed to attack gram-positive peptidoglycan,
It doesn't matter how high the dose is.
it's like trying to unlock a highly advanced biometric safe with a physical brass key. The mechanism just doesn't translate at all.
Exactly. You could give a technically lethal dose of that antibiotic, and the gram-negative bacteria would remain completely unaffected. The drug isn't weak. It simply lacks the specific mechanism of action required for that target.
See, that right there immediately nullifies the idea of a universal strongest pill.
It completely dismantles it.
So what about the second pillar, the site of the infection? This is where I struggle a little bit to understand because, once I swallow a pill or if I get an IV, the drug enters my bloodstream and my blood circulates everywhere in my body. So why does the physical location of the infection dictate the type of antibiotic? Doesn't the blood just take it there?
That's a very logical assumption, but no, because your body is highly compartmentalized. It actively restricts where substances in the blood can actually go.
Give me an example.
The most famous example is the blood-brain barrier. The capillaries in your brain are lined with endothelial cells that are packed incredibly tightly together with tight junctions. And they are further insulated by these star-shaped cells called astrocytes.
Okay, so it's heavily guarded.
Very. This barrier is incredibly selective. It really only lets in molecules that are highly lipophilic, meaning fat-soluble, and very, very small.
Ah. So if I have bacterial meningitis, an infection literally inside my brain, I can have the most potent bacteria-killing drug circulating in my veins. But if the molecule is hydrophilic, if it dissolves in water instead of fat, it will literally just pass right by the brain and never touch the infection.
Precisely. It just washes right past.
Hmm.
We have to select an antibiotic specifically for its biochemical ability to penetrate that specific barrier. Or let's look at a lower urinary tract infection, a UTI.
Okay, how does that work?
For a UTI, we actually want a drug that the body actively tries to get rid of quickly.
Wait, really? Why?
Because we want an antibiotic that is not heavily metabolized by the liver, but is instead rapidly filtered out of the blood by the kidneys and then dumped, fully intact and highly concentrated, straight into the bladder.
Oh, wow. That is fascinating pharmacology. You are essentially using the body's own waste disposal system to deliver the payload right to the infection.
Yes. It's brilliant, right? But if you have a lung infection, like pneumonia, that exact same UTI drug might be completely useless.
Because it just goes straight to the bladder instead of the lungs.
Exactly. It doesn't concentrate in pulmonary tissue. So again, it's about the pharmacokinetics, how the body moves the drug, not the brute strength of the compound itself.
Which brings us perfectly to the third pillar.
Yeah.
Resistance patterns.
Mhm.
And I want to get granular here because I feel like the public understanding of antibiotic resistance is often just this vague idea of, oh, the bacteria get used to the drug. But it's actually an active evolutionary warfare occurring at a microscopic scale, isn't it?
It is incredibly aggressive. People don't realize how fast bacteria replicate. Some can replicate every 20 minutes. And with every single replication, there is a chance for a genetic mutation.
Right.
But they don't just sit around and wait for random mutations to happen. Bacteria engage in something called horizontal gene transfer.
Horizontal gene transfer, what does that mean?
They have these little circular rings of DNA called plasmids, which contain resistance genes. A bacteria that has figured out how to survive an antibiotic can literally extend a microscopic tube, it's called a pilus, and hand a physical copy of that survival blueprint to a completely different species of bacteria.
Wait. They share blueprints across species lines.
They do.
So a totally harmless bacteria in my gut could theoretically learn how to defeat an antibiotic and then literally hand that knowledge over to a lethal pathogen that entered my body later.
That is exactly what happens all the time.
Yeah.
And the mechanisms they use to defeat the drugs are honestly brilliant.
What kind of mechanisms? Like, how do they stop the drugs?
Well, some bacteria produce enzymes like beta-lactamases, which act like microscopic scissors. They physically snip the antibiotic molecule in half before it can even work.
Wow.
Yeah. And others develop afflux pumps. They literally build a mechanical pump in their cell wall, so the absolute moment the antibiotic enters the cell, the pump just spits it right back out.
It's a biological bailing bucket. It's just
Yeah.
throwing the water out of the sinking ship.
Yes. And this is exactly why doctors have to consult local antibiograms. The resistance patterns in a hospital in New York might be entirely different from the patterns at a clinic in rural Texas. A doctor has to know not just what bacteria they are fighting, but what specific weapons that local strain has already learned to defeat.
Man, it really is warfare. And the fourth pillar is the patient's own individual biological factors.
Hmm.
I assume this ties heavily into the renal and hepatic clearance we talked about earlier with the kidneys and the liver.
It does, very heavily. A doctor has to look at your glomerular filtration rate, which is basically how well your kidneys are filtering blood. If you have chronic kidney disease, and I give you a standard dose of an antibiotic that clears heavily through the kidneys, it will bottleneck. The drug will build up to toxic levels in your blood, and that can potentially cause permanent hearing loss or severe neurological damage.
Just because the dose wasn't tailored to your specific organ function?
Exactly. They have to factor in your renal function, your age, your immune status, your specific allergies, and even whether you are pregnant, because pregnancy drastically changes human hemodynamics.
Okay, so let's put this all together. A patient walks into a clinic feeling awful, demanding the strongest drug. They are totally blind to the structural armor of the bacteria, the pharmacokinetics of their own organs, the genetic plasmids being swapped in the local microscopic environment, and their own renal function.
Completely blind to all of it.
It really highlights how deeply absurd the demand for a silver bullet truly is. But this actually raises a major logistical question for me. If doctors need all this hyper-specific data to choose the right microscopic screwdriver, what happens when a patient arrives crashing? They're in septic shock. You don't have 3 days to grow a culture and identify the specific pour-in channels of the bacteria. You have to act now.
And that right there is the absolute crux of modern infectious disease management. It's the delicate transition between two distinct phases of care: empiric therapy and culture-guided therapy. When a patient arrives severely ill, you are right, we cannot wait. We initiate empiric therapy immediately.
But empiric therapy, just by definition, implies observation and experience. It's an educated guess, isn't it?
It is, but it is a highly calculated, statistically driven guess. The physician evaluates the presentation. For example, if a 70-year-old patient comes in from a nursing home with a severe cough and low oxygen, statistical data strongly suggests certain likely pathogens,
Like what?
like Streptococcus pneumonia, or perhaps a gram-negative enteric bacteria if there's a risk they aspirated something. The doctor will prescribe a regimen that covers the most likely culprits based on those local antibiograms we talked about. This almost always involves what we call a broad-spectrum antibiotic.
And here is where the massive psychological trap springs shut for the patient.
Oh, big time.
Because the public hears the phrase broad spectrum and they immediately think, the strongest one, the one that kills absolutely everything. Why don't we just use that from the very beginning for every single infection?
Exactly. Broad spectrum sounds like the ultimate silver bullet. It acts like a biological EMP, an electromagnetic pulse that just knocks out the power grid of a vast swath of bacteria, both gram-positive and gram-negative.
Right.
But while that EMP is going off in the patient's body, the laboratory is running diagnostics in the background. Historically, this meant streaking the blood or the sputum onto an agar plate, waiting days for it to grow, and then placing little tiny discs of antibiotics on the plate to literally see which ones inhibit the growth.
Right, the zone of inhibition, where you measure the clear circle around the little disc to see if the drug effectively killed the bacteria.
Right. But today, the technology is advancing so rapidly. Hospitals use malady-toph mass spectrometry, which literally uses lasers to vaporize the bacterial proteins and measure their time of flight to identify the exact species in minutes instead of days.
Wow, lasers, okay.
Yeah, and they use multiplex PCR arrays that scan the bacterial DNA for specific resistance genes. They are looking directly for the genetic blueprint of that beta-lactamase scissor we mentioned.
So the goal is to shift from the broad-spectrum EMP of empiric therapy to the highly targeted sniper rifle of culture-guided therapy as rapidly as humanly possible.
Yes. The absolute moment the lab identifies the specific bacteria and its vulnerabilities, the doctor must engage in de-escalation. They take the patient off the broad-spectrum EMP and switch them to a narrow-spectrum drug that only kills that one specific pathogen.
But wait, let me play devil's advocate here.
Yeah.
If the broad-spectrum drug is already working, Like if the patient's fever is going down, their blood pressure is stabilizing. Why change it? I can literally hear the patient now. Doc, whatever you gave me in the ER is working. Don't switch it out for a weaker, narrow-spectrum drug. Why is it so inherently dangerous to just leave them on the EMP?
Because of the collateral damage. And this takes us directly into the massive safety implications that the iMedix document focuses on. When you use a broad-spectrum antibiotic, you aren't just attacking the invading pathogen. You are literally carpet bombing your own microbiome.
The microbiome.
Yeah.
The trillions of bacteria that live in the human gut. I feel like we are finally starting to realize as a society that the gut isn't just a digestion tube. It's practically its own organ system, right?
It is. It is a highly complex, fiercely competitive, microscopic ecosystem. The good bacteria in your gut, they synthesize vitamins, they regulate your immune system, and they fundamentally protect you simply by taking up space.
Taking up space, like biologically.
Yeah, it's a concept called colonization resistance. Think of it like a crowded movie theater. If every single seat in the theater is filled by a good bacteria, a bad actor can't sit down. There's no room for them to establish an infection.
Ah, so when the broad-spectrum antibiotic goes off,
Yeah.
it indiscriminately slaughters the audience.
It burns the theater to the ground.
Oh, wow.
And this creates a massive biological void, which introduces one of the most terrifying opportunistic pathogens in modern medicine, Clostridioides difficile, commonly known as C. diff.
I've heard of C. diff. It's notorious in hospitals.
Yeah.
But wait, if the broad-spectrum antibiotic kills everything, why doesn't it kill the C. diff too?
Because C. diff is uniquely equipped for biological warfare. When it senses a hostile environment, like the sudden presence of a broad-spectrum antibiotic, it forms a spore.
A spore?
Yes. It essentially locks its DNA inside a highly durable biological vault that is completely resistant to heat, acid, and most antibiotics. So the EMP goes off, the healthy gut flora is vaporized, and the C. diff spores just sit there and wait.
Oh, that is incredibly sinister.
It is. Once the antibiotic concentration in the gut finally drops, the spores germinate. And because there is absolutely no healthy bacteria left to compete with them for nutrients, the C. diff multiplies exponentially. It completely takes over the colon and begins pumping out two incredibly destructive proteins, toxin A and toxin B.
What do the toxins do?
These toxins literally dismantle the structural scaffolding of the cells lining your colon. This causes severe inflammation, massive fluid loss, and the formation of false membranes, which is called pseudomembranous colitis. If it isn't treated rapidly, it can escalate to toxic megacolon and eventually death.
So let me get this straight. By demanding the strongest broad-spectrum antibiotic for a relatively minor issue, like, say, a prolonged sinus infection, you not only didn't fix the underlying issue efficiently, you actively cleared the battlefield for a lethal spore-forming superpathogen to basically rot your colon from the inside out.
Exactly. You engineered your own secondary crisis because you equated pharmacological broadness with efficacy. You thought bigger was better. And that is just the individual harm.
There's more.
Oh, yeah. The iMedix document heavily stresses that medication safety with antibiotics is a collective, systemic issue. It is the ultimate biological tragedy of the commons.
Okay, wait. How does my bad decision, driven by my own psychological desire for a quick fix, affect the global ecosystem? Like, how does my sinus infection impact anyone else?
Because every single time you take an antibiotic inappropriately, you are running a forced evolutionary boot camp for bacteria. Let's say you take an antibiotic for a viral infection like the flu or a common cold.
Which is useless because antibiotics don't work on viruses.
Right, viruses don't have cell walls or bacterial ribosomes for the drug to target. The drug does absolutely nothing to the virus.
Yeah.
But it does interact with the billions of bacteria naturally residing in your body.
Right. It applies selective pressure.
Exactly. It kills off the weak, susceptible bacteria, and it allows the one or two bacteria that happen to have a random beneficial mutation to survive. Those survivors multiply. They share their resistance plasmids with other bacteria.
The blueprints we talked about earlier.
Yes. And eventually you excrete them, they enter the wastewater, they interact with environmental bacteria, and those resistance genes spread globally?
It's an invisible arms race.
Yeah.
And we are literally handing the blueprints of our own weapons directly to the enemy.
We are. And because of this, we are seeing the rise of pan-resistant bacteria, pathogens that carry genes like NDM1 New Delhi metallobeta-lactamase, which can render almost our entire modern arsenal of beta-lactam antibiotics completely useless. We are staring down the barrel of a post-antibiotic era.
A post-antibiotic era.
Yes, an era where routine surgeries, cesarean sections, and minor scrapes could become fatal simply because we exhausted our miracle drugs trying to satisfy patient demands for a silver bullet.
That is a staggering reality. It's no longer just about a doctor managing one individual patient's expectations in a clinic room. It is about defending the future of modern medicine from our own psychological flaws.
It really is.
Which naturally transitions us into how the system tries to fight back. Because clearly, we cannot rely on the individual patient in a moment of pain and panic to make a rational choice about global microbiome ecology. We need some kind of systemic friction, right?
Absolutely. And that friction comes in the form of regulatory context, which is the final major component of the iMedix analysis. Medical authorities have had to physically encode medical reasoning into the bureaucratic and digital architecture of healthcare to basically stop the abuse of these drugs.
Give me a concrete example of that architecture. How does a hospital actually stop a well-meaning doctor from caving to a patient's intense demand for the strongest drug?
The most prominent mechanism today is the implementation of antimicrobial stewardship programs. In modern electronic health record systems, if a physician tries to prescribe a highly potent broad-spectrum antibiotic like a carbapenem for a routine infection, the software will literally produce a hard stop.
A hard stop, like an error message.
Worse, it will not allow the order to physically go to the pharmacy.
So the computer physically blocks the sledgehammer.
Yes. The physician is forced to stop, consult with an infectious disease specialist or an antimicrobial pharmacist, present the clinical data, show the culture results, and justify exactly why the narrow-spectrum alternative is insufficient. It is a mandated pause. It forces the human system to prioritize appropriateness over perceived strength.
I imagine doctors face incredible hostility from patients over this.
Yeah.
What do you mean you have to ask a committee to give me the good stuff? Just write the prescription.
Oh, they face immense pressure. And this is exactly why regulatory agencies like the FDA have to intervene at the highest possible level with tools like the black box warning. A perfect case study for this dynamic is a class of antibiotics called fluoroquinolones, drugs like ciprofloxacin.
I've definitely heard of Cipro. People used to get prescribed that constantly. It was viewed as the ultimate, reliable, heavy-duty pill.
It was viewed as the ultimate silver bullet. And because it was so highly effective, it was massively overprescribed for uncomplicated infections like simple UTIs or bronchitis. But fluoroquinolones are incredibly intense drugs. They work by inhibiting bacterial DNA topoisomerases.
Alpha what?
Topoisomerases. They are enzymes that basically unwind DNA during replication. So the drug stops the bacteria from copying its DNA. But the problem is they can also have severe downstream effects on human tissue.
What kind of effects? I feel like I've heard rumors about tendon issues with Cipro. Is that true?
It's not a rumor. Fluoroquinolones can upregulate matrix metalloproteinases. These are enzymes in the human body that naturally break down collagen. As a result, patients who were just taking these antibiotics for a simple, annoying sinus infection were suddenly experiencing spontaneous Achilles tendon ruptures.
So spontaneous, like just walking down the street.
Just walking down the street, stepping off a curb, and their tendon would just snap.
Good Lord.
Yeah.
All because they wanted a strong drug for a sniffle.
Tendon ruptures, irreversible peripheral neuropathy, severe central nervous system toxicity. The collateral damage was so severe that the FDA had to issue their absolute strongest possible regulatory action, a black box warning.
Wow. What does the warning actually say?
The warning explicitly dictates that the risk of these severe adverse effects far outweighs the benefits for patients with acute sinusitis, acute bronchitis, and uncomplicated urinary tract infections. It flat out states they should only be used in patients who have literally no alternative treatment options.
That is the ultimate systemic friction right there.
Yeah.
The FDA is stepping in to shatter the illusion that strongest equals best. And I have to say, as I'm listening to this whole breakdown, this dynamic of perceived strength versus actual safety,
Yeah.
it's in isolated antibiotics. This maps perfectly onto one of those catastrophic medical crises of the last century.
You're thinking of the opioid epidemic.
Yes, it is the exact same psychological trap. Think about it. A patient comes into a clinic with a sprained ankle or some lower back pain. They are suffering. They want the absolute strongest painkiller available to make the pain stop instantly. They want the silver bullet.
Right.
And if the physician prescribes physical therapy and a mild NSAID like ibuprofen to target the localized inflammation, the patient feels dismissed. They feel like the doctor's holding out on them. They want the fentanyl or the oxycodone.
The parallel is incredibly sharp because in both cases, the patient demands maximum pharmacological force, entirely ignoring the collateral damage. With opioids, the drugs target the mu-opioid receptors in the brain and spinal cord. They are incredibly effective at blocking the perception of pain.
But they come with a massive cost.
Exactly. They also severely depress the respiratory center in the brainstem, and they trigger this massive dopamine release in the reward pathways, leading to rapid, profound physiological dependence.
Right. So prescribing an incredibly potent opioid for minor acute pain is a profound medical error. It exposes the patient to an unacceptable risk of dependency, respiratory depression, and fatal overdose, all for a localized problem that did not require that level of systemic force.
It's the sledgehammer again.
Exactly. Just like giving a broad-spectrum carbapenem for a mild sinus infection exposes the patient to lethal C. diff and drives global antibiotic resistance.
In both scenarios, the human psychological drive for immediate absolute relief completely overrides the biological reality of the body's systems. And in both scenarios, the regulatory framework has had to aggressively step in. We see prescription drug monitoring programs and strict prescribing limits for opioids, which perfectly mirrors the antimicrobial stewardship programs for antibiotics. The bureaucracy exists to protect the patient from their own instincts.
But this highlights a huge vulnerability, doesn't it? Because a black box warning on a label or a hard stop pop-up in an electronic health record is dry, bureaucratic, and largely invisible to the actual patient sitting in the room.
Completely invisible.
If a doctor says, "I can't give you this drug because of an FDA guideline," the patient doesn't suddenly understand pharmacology. They just get angry at the government. They feel like the bureaucracy is just hoarding the good stuff.
Which brings us full circle to the very existence of the iMedix document. Regulatory guardrails are completely insufficient if they are not paired with comprehensive patient education. We cannot just enforce the rules, we have to translate the why behind the rules.
You have to explain the mechanism.
Exactly. When a patient actually understands the mechanism of a C. diff spore, or when they understand how prescribing broad-spectrum drugs to a child today might ensure that child has absolutely no viable antibiotics left when they are an adult, the psychological demand for the silver bullet evaporates. Education aligns patient expectations with medical reality.
And that is the true value of independent platforms that can strip away the dense academic jargon without losing the scientific depth. As we synthesize everything we've unpacked over the last hour, the overarching narrative is just profoundly clear. We started with what seemed like a purely logical question. What is the strongest antibiotic?
Right.
And through this iMedix framework, we've realized that the question itself is structurally flawed. It is a question based on an illusion.
It is an illusion that stems from treating our biology like a war zone that simply needs a bigger bomb.
Exactly. We've dismantled that action movie mythology. We explored the reality of medical reasoning, how physicians are not hunting for raw power, but for absolute precision. They are analyzing the structural armor of gram-positive versus gram-negative bacteria.
That peptidoglycan versus the lipid membrane.
Right. They are navigating the incredibly complex pharmacokinetics of the blood-brain barrier in renal clearance. They are tracking the real-time genetic evolution of resistance plasmids in local environments, and they are tailoring everything to the specific metabolic constraints of the patient sitting right in front of them.
We differentiated the necessary educated guess of empiric therapy from the precise targeting of culture-guided therapy. And we confronted the devastating reality that broad spectrum is not a synonym for better.
It's the biological EMP, the forest fire that leaves your microbiome completely desolate and vulnerable to horrifying opportunistic pathogens, while simultaneously acting as a boot camp that trains the next generation of global superbugs. It is a stark reminder that in medicine, brute force is often just a mask for structural damage.
And as we close this deep dive, I really want to leave you with a final thought to mull over. We have spent this entire time looking at how human psychology, our demand for the silver bullet, the immediate fix, clashes with the biological reality of how drugs actually work. But think about the profound evolutionary pressure that psychology creates. If our impatience continually drives us to overuse the most extreme medical tools we have, how is our psychological flaw actively dictating the future biological evolution of the pathogens that hunt us? Are our own minds engineering the very superbugs that will outlast us?
Wow, that is a heavy thought. Next time you reach for the bleach to clean a stain, or the next time you find yourself sitting on a crinkly paper table in a clinic, feverish, wanting the doctor to just give you the strongest pill in the cabinet or the mechanical watch and the sledgehammer, precision, not power, is what truly heals. Until next time.